Hi, Paul Ridker, Mike Gibson coming to you live from ACC 2023, and we're talking about the residual risk due to inflammation. Paul, you presented information from 3 big trials: Prominent, Reduce It, Strength, people on statin therapy, but they still have a lot of inflammation. What did you find?
So Mike, we got to put this thing in perspective. It's been 25 years, literally, since we showed for the first time that in primary prevention, people not treated, that LDL and representing lipids and CRP representing inflammation are both powerful predictors of the future of this disease.
Independent of each other.
Independent of each other and additive to each other, right? And we've learned over the years that statins are terrific lipid-lowering drugs that also have anti-inflammatory effects. We've learned over the years that there are drugs that can target this inflammatory system without lowering the LDL that lower risk. And of course, we all know there's lots of LDL-lowering drugs that lower risk that don't affect inflammation, so that's all interesting, good stuff.
And there's some drugs out there that rise inflammatory markers, and that's bad.
That's bad. So I sat there and said, okay, in contemporary clinical care, I wanted to know if the relationships we saw 25 years ago had changed or not. So I sat down with our own Prominent trial data, where we had access to it because we had run that trial. And I simply said, let's look at what's the predictive value on a statin, on a high-intensity statin, predictive value of the LDL levels and of the CRP levels. I was expecting them to be similar. To my surprise, the LDL was a pretty mild predictor of future events.
This is the on-treatment LDL?
Yeah. The LDLs are now in the 70s.
Yep.
But we all want to lower it further, right? And our guidelines say we should, and we should.
Right. But
the CRP was an incredibly powerful predictor of these recurrent events.
Independent of?
Well, for cardiovascular death, it's like a 3-fold gradient of risk. Whereas for LDL, it's like a 1.1 across 4 quartiles.
Yeah. So we got this residual risk factor out there of inflammation
that we're not addressing. But then I said, well, I'm not going to publish that because that's one study. I better get some external validation. So I called up Steve Nissen and I said, hey, Steve, can I get access to Strength? And I called up Deepak Bhatt and said, hey, can I get access to Reduce It? And you might say, why those 3 trials? Well, it's really important because they're all contemporary. They're all guideline-directed medical therapy. Almost all are universally on a high-intensity statin. And all 3 were giving interventions that don't affect LDL and CRP. So it wouldn't be confounded. To all of our surprise, the data I saw, the results I had in Prominent are exactly what happened in Reduce It, and they're exactly what happened in Strength. So all 3 trials showed the same thing. This residual inflammatory risk that most of our colleagues aren't even measuring, 25 years later, is a more powerful predictor by far than the LDL levels. Now, you and I clearly know that lowering LDL matters absolutely. When we talk about inhibiting inflammation, we're not talking about competing with that. We're talking about, in addition to lipid lowering, can we address this? So we then did a meta-analysis, some sophisticated math was done, but when all 3 are identical, you know the result. So we've got about a 3-fold increased risk of all-cause mortality and of cardiovascular death for CRP, and pretty mild effects at all for LDL.
And this is in 30,000?
And this is in 31,245 contemporary patients.
So Paul, what are we going to do? I mean, I know you're very active in this field. Tell us about some of the shots on goal you got coming up.
Well, first, there's things we should do right now. It's a little embarrassing to me that we are 30 years into this and our guidelines still don't say to measure CRP universally. And I don't understand that. I would never treat a patient with a lipid-lowering drug without knowing their LDL. I would never put anyone on a blood pressure-lowering drug without knowing their blood pressure. So why haven't we just endorsed CRP as a routine screen? I have no idea. It doesn't make sense. And our guidelines are just outdated. That's just a fact. That's number 1. Number 2, we've known for a long time if you do have an elevated CRP, there's things you can do that the guidelines do support. Diet, exercise, smoking cessation, all increase CRP. They all increase risk. And so I've used this for years to motivate my patients to do the right thing. And I think the guidelines would be very happy with that. But we've also known now for 5 years, when CANTOS was published, that we could lower inflammation and lower risk. So again, we have to ask the question, well, why aren't we endorsing this? Well, with canakinumab, as you're well aware, we don't have access to that drug because in addition to it showing efficacy, it also had this great effect on lung cancer, so it's not available to us as cardiologists. But we've got 2 randomized, double-blind, placebo-controlled trials of colchicine, the low-dose colchicine 2 trial and the Colcat trial. They're both about 5,000 patients, and they show a 32% relative risk reduction. I'm going to repeat that. A 32%. Now, wait. We all using PCSK9 inhibitors. That's 15 to 17%. We saw data here for bempedoic acid yesterday, 13%. And, you know, this is 32%, and it's an inexpensive drug. And Mike, when I take polls of my colleagues, people look at me like, I'm not using that drug. And I say, well, why not? They say, well, I don't really know anything about it. Haven't heard about it. So it's an education problem.
Right.
It's a classic problem in American medicine of there's no big pharmaceutical support, so we're not doing
Nothing to treat it, so I'm not going to measure it.
Well, there's plenty of things to treat it. It's just that we're not measuring it and we're not treating it. And again, I think it's the difficulty here. Now, let's be careful. I would not give colchicine to all my patients. First of all, very important to point this out. Patients with chronic kidney disease cannot take this drug.
Right.
Okay? But in my clinic of atherosclerosis patients, 4 out of 5 don't have CKD. The one who does, not going to get this drug. I think it's a reasonable thing to do with our frequent flyers, right? The patients who just keep coming back no matter what we do. And I think that could be done right now. It's inexpensive and it clearly works. CKD raises a whole different set of issues. Oh, by the way, one other issue with colchicine, just so people are aware, you don't want to give this drug concomitantly with an antifungal like ketoconazole or fluconazole. And there's a few other things like that. So if the primary care doc puts them on that for their toenails, got to stop the colchicine for that week or two.
Got it.
But that's not a big deal.
Now, Paul, why do we still have this residual elevated CRP? I mean, here we got people's LDL down. Talk to me about the role of Lp(a), another kind of form of LDL. Is that one of these untreated risk factors? I'm someone who has an Lp(a) that's 2.5 times the upper limit of normal. And I didn't know about it. Nothing, exercise isn't going to drive it down, diet isn't. What role is that playing in some of the residual inflammatory risk? Or do we know why these people are inflamed?
Right, so Lp(a) is in this sort of panoply of novel biomarkers that do tell us something about risk. We're well aware that there are ongoing clinical trials of Lp(a) lowering drugs, and we all hope they're going to be positive because it gives us another way of approaching that relatively unique patient. I am someone who says we should measure Lp(a) once. Right, it's genetically mediated, so there's no reason to measure it more than once. And we'll see what happens with these clinical trials. Whether that is or isn't adding to the inflammatory burden is actually quite controversial. There's some data that says it does, some data that says maybe it doesn't. And the clinical trials will help us out there. The real direction in the inflammation hypothesis, though, is going down this cascade. So it gets a little technical. Remember, we have the NLRP3 inflammasome. That activates IL-1 beta and IL-18. They have vascular effects that are bad. They also upregulate the central signaling cytokine interleukin-6.
Right.
And IL-6 is really central to all this.
And that's what drives up your CRP.
And exactly, that's what drives the biomarker up.
Right.
So there are some very novel interleukin-6 inhibitors that we are now putting into atherosclerosis clinical trials. We're working with Novo Nordisk. They have a drug called ziltivekimab. It's a mouthful. Ziltivekimab is a therapeutic monoclonal antibody that targets the IL-6 ligand. It's not like tocilizumab, which is a receptor antagonist for IL-6. So remember, canakinumab, Cantos, was an interleukin-1 beta monoclonal. This is one step downstream because we think that's the ultimate target. In Cantos, we saw some data that said the bigger the IL-6 reduction, the greater the benefit. So okay, so let's target IL-6. We did a clinical trial called Rescue. That was a phase 2 study that showed that if I gave this novel drug, I could drive the IL-6 levels down 85, 90%, which is twice the IL-6 reduction we got in Cantos. Last night at the ACC, we had our investigator meeting for what's called ZEUS, the ziltivekimab cardiovascular outcome study. ZEUS is specifically focusing on the CKD patient. Why? I can't give them colchicine. Right? So I said, okay, this is where we should start. So these are patients with known atherosclerosis, stage 2 or 3 chronic kidney disease, and an elevated CRP.
Right.
We both know incredibly high cardiovascular risk. Unfortunately, the most common cause of death of those patients is vascular. It's not renal. So they're getting randomized, because I can't give them colchicine, to this novel IL-6 inhibitor or placebo. We've just randomized 40% of the total of the 6,200 patients we ultimately need. It's being run globally. And hopefully in a couple of years from now, we'll know, aha, here's another way of getting there, particularly for these extremely high-risk, unmet medical needs CKD patients.
Yep.
Now, Novo Nordisk has also announced publicly that a second trial with this drug, ziltivekimab, is going to be launched in HFpEF.
Wow.
So heart failure is an interesting setting where there's a lot of evidence suggesting inflammation plays a role. The only data is our CANTOS data, which was kind of post hoc, that showed that we had a reduction in hospitalization for heart failure, or HHF. But we didn't do echoes, so I don't know if it's HFpEF or HFrEF. For some biologic reasons, we think the target's HFpEF. So that clinical trial is called Hermes. Some Greek gods here.
Some Greek god thing going on. Okay.
And there's a third trial that we think is going to get funded called Artemis, just to stay with this analogy, which is going to be ziltivekimab in acute coronary ischemia and acute myocardial infarction. So that's the landscape, and it's very exciting because I think we've been buddies forever,
Right.
but watching the inflammation thing move into the mainstream is what's happening, and it's very exciting.
Well, thank you. Congratulations on leading that field. And thank you for joining us here live from ACC 2023.